Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren, the executive editor of MedEvidence, and I've been having this fabulous conversation with Dr. Ali Kasraeian, a urologist and a media person and somebody that's involved in organized medicine. In our last segment, we were just talking about the controversy around PSA and how you have to customize the number that you get to the specifics of a person. So high-risk people, you're going to be more aggressive if you had a family history or African-American, for example. And lower-risk people, maybe you watch it for a longer period of time. But interestingly, even when you get to imaging, there's ways of getting a sense for what the prognosis will be over the next 5, 10, 15, 20 years. So that was a fascinating discussion. So let's jump into that point about what you see as the future for getting better at diagnosing prostate cancer and also identifying the people that truly need to be treated aggressively.
Yeah, it's smarter screening. PSA can save your life. Talk to your doctor about PSA screening. Know your family history. So if we start with a lab test and it's concerning, then we kind of talk about what to do next. If you show up with a PSA of 10, we recheck it's still elevated, it makes sense to do a biopsy. I think the MRI allows us to do a better biopsy. If we're on the fence, you've had repeat negative biopsies and things of that nature, then, can we use biomarkers? Biomarkers are lab and urine-based tests that can help guide us to see what is the probability or the possibility that your elevated PSA is due to not just a prostate cancer, but a intermediate or higher risk prostate cancer, meaning a prostate cancer that if we found, we would treat. Mm-hmm. A lot of times these tests, if the score is in the lower range, that risk is low. Mm-hmm. If it's in the intermediate to higher range, it's an incremental higher risk. We can take that with an MRI scan, put them together, and give a discussion or initiate a discussion of what is the risk, what is your comfort level, what is our next move, and we can personalize it to you, your history, and other medical issues that you're going through in your age.
So starting with the diagnosis, are there specific biomarkers other than PSA that you can mention
absolutely.
in this podcast?
So the three that I use, right now, one blood-based test that I use quite a bit is a thing called the 4K score. It looks at PSA with three other cousins, intact PSA, is total PSA, free PSA, intact PSA, and this thing called HK2, a human kallikrein protein 2, which are kind of all in the same family.
So a doctor has to order that specific panel.
It's a lab test, yeah. Mm-hmm. And then it comes back with a score, and if the score is in the lower risk range, you have a very, very low risk of having a intermediate or higher risk prostate cancer. And
is that something you should do before just getting a standard PSA, do you think?
No, because honestly, if you have a low risk, a low PSA, a stable PSA, why would you leap to another test like that? Because what if it comes back with an in-between result and now you have a low PSA? And it's only valid for PSAs that are a little bit increased anyway, from that standpoint. Two urine tests that are wonderful and great science with them. One's an exosome DX test, an exosome DS test. Beautiful science that they found that exosomes, which we before thought just had mitochondria, actually have messenger RNA in them. And so they found it coming off urine. It carries with it messenger RNA and great genetic and DNA information, carbon copies of it coming off urine. They could get prostate information, so that first part of the stream, and they can get predictive information of the risk of prostate cancer off it. Amazing science. So if you're in the low level, the risk of having a prostate cancer that's 7 or higher is a little bit higher. If it's in the low range, it's a very low risk of that, so you can do that. And during the COVID pandemic, we were very fortunate to be part of the first team using that on an at-home test, and it was really, really powerful for us to use to be able to guide patients on whether they need to come in and talk about doing a biopsy at a time where people didn't want to leave their house. So that was really powerful. Another one's called...
Again, that's not for people with a low PSA. Those are people that are identified as having higher PSAs and taking the next step.
Yeah, so someone with a PSA change that we want to be mindful of, do we need to do a biopsy next? Right. From that standpoint.
And with that test, if it was negative, make you feel comfortable that you don't need to do imaging of the prostate?
So, that's a very controversial discussion, and there are a lot of papers looking at that, and we as urology have not come up with an absolute answer for that. For some people, the MRI scan first makes sense. For some people, doing the biomarker first makes sense. Some people are the genetics trump the imaging. Some people imaging trumps that. So for me, it's a very personalized approach, from that standpoint. So really, for me personally, it's a patient-by-patient discussion.
Got it.
Another test that we use frequently is the My Prostate score. It's a newer of the three. Great test, and what I like about this test is a very high negative predictive value. So for someone who's never had a biopsy, they have a 95% negative predictive value, meaning that if your score is in the low range, you have a 95% likelihood of not having prostate cancer. If you've had a previous negative biopsy, you have almost a 99% negative predictive value. So that's very powerful. So I use it often with people who've had negative biopsies, and then we want to think about whether or not to do another biopsy, especially if they have had a negative MRI scan.
Yeah. So for listeners out there, tests that have a high negative predictive value usually have a very high sensitivity. So they pick up things. So when they're negative, you feel pretty comfortable that you're not dealing with the problem.
Yeah.
The flip side is when they're positive, it doesn't always mean that you have the problem.
Yeah, it tells you that search further.
Right.
And that's how I kind of counsel people. If this is a higher, it doesn't mean that we have cancer.
Right.
Absolutely. It just means that we should probably look. If it's negative, we feel comfortable that it's negative.
Any other novel biomarkers that you want to?
One thing that's really interesting that's not quite as novel, but something to keep in the back pocket, there's some tests that we actually use when people have had previous biopsies to decide in the next biopsy if their PSA changes. There's a test called the Confirm MDX where you can actually go back and look at the genetics of a previous negative biopsy, and it can tell you at any of those cores that you took, could there be genetic changes that could heighten the risk of a positive biopsy at that site? So then when you do the next biopsy, it can help guide you to take a few more cores at that site. And that's in the diagnostic phase. And then there are what are called genomics tests that you can do after the biopsy that can then guide you in terms of the therapeutics and the treatment, active surveillance versus treatment, so you don't, again, undertreat a cancer that may be able to be monitored versus overtreating a cancer that can be watched, and then undertreating a cancer that should be treated.
And you mentioning about AI maybe helping people with decision making. So I know a big issue, of course, is once you're diagnosed with prostate cancer, do you take the prostate out? Do you treat it locally?
So the treatment for prostate cancer is always, very controversial, and the thing that often drives a lot of people away from actually screening because they think everyone needs a prostatectomy, everyone needs radiation. And unfortunately, with both of those technologies, with the advances in robotics, the advances in radiation therapy, especially in high volume centers, the side effect profiles are getting better, but they're not perfect. So in doing that, we want to see, can we offer people things like focal therapies now with high intensity focused ultrasound, cryotherapy, focal laser ablations, a lot of these technologies where if you have a targetable lesion, and that's the only area that we have cancer, can we just treat that area and leave the unaffected portions of the prostate untreated? And so the more prostate you preserve, the more function you preserve. Is that safe to do? We're working with a company, and we're very fortunate to have been early in the adoption of this technology called Unfold AI by a company called Avenda Health. Really well-validated technology where you take the MRI scan, the biopsy, and then put all of the information together, and it tells you how much of the prostate you have to treat, meaning target plus a margin, to give you a very high confidence that you treated all the cancer with a high cure rate probability. And so you can talk to the patient about exactly what we need to do and whether they're a wonderful candidate for focal therapy or we should actually pursue a whole gland treatment. And so that's another way you can personalize the treatment so you don't undertreat a cancer that needs a more robust whole gland treatment, and then you can very appropriately offer a person a focal therapy. And it's a wonderful technology, very smart. And the way from a data standpoint it was monitored, or whether it was studied, is they took the MRI scan compared to a whole mount prostatectomy, meaning they sliced the pathology specimen like an imaging study, had radiologists look at it by itself, had AI look at it by itself, and look at it together, and they found the AI actually did better than the radiologists by themselves, but both together did better than each alone.
Interesting.
Amazingly well validated.
Are there multiple companies that are pursuing these concepts, or is it?
Absolutely. I mean, there are more companies and there are more to come. The big thing for us to be mindful is how they're validated, how the science goes. And AI, like every AI that we look at, we have to be mindful of AI is only as smart as a teacher.
Sure.
So what goes in it makes what comes out as smart as it can be. And what I really like about this technology, it is really smart. The CEO of the company, his PhD was in MRI and MRI sciences for the prostate. I mean, I don't know how much more specific you can get from that in terms of a PhD. But very smart people looked into it, and they continue to advance it and put more data into the technology. So it continues to grow with a very specific focus on having people have better options of treating their prostate cancer and more information to make better choices. Again, it's personalizing it, very similar to breast cancer. So when people get diagnosed with breast cancer, the amount of information they have at diagnosis to make very wonderful personalized choices for their present and their future, and also for the genetic information for their family's future. And with prostate cancer, we're looking to catch up, and we're I used to say we're about 20, 30 years behind breast cancer. We're catching up. And I think in the next several years, we're going to be very, very quick to that, especially in advanced prostate cancer. The amount of medications and the science going into that field is revolutionary, and our guidelines keep changing faster than we can keep up, which is a great thing.
Interesting. We're getting to the end of our time together, but any clinical trials that are ongoing that are particularly fascinating to you?
Many. We're always trying to push envelopes in terms of better studies for the focal therapy avenue with diagnostics. There are always things going on in the advanced prostate cancer. There are many things. I mean, it's not quite related to this, but when people are diagnosed with prostate cancer, advanced prostate cancer, or metastatic prostate cancer, historically we used to give a hormone blockade medication, and there's some studies that came out in the past couple of years where you can give a pill by itself and had similar outcome for people that had recurrent prostate cancer. We're hoping those studies continue so you can potentially treat those patients better. We're now, we hope to move and make those kind of diseases, those parts of this disease that used to be uniformly fatal, we're approaching where we're having 30 to 60% radiographic response rate, where things that used to be on imaging are no longer there. Outcomes are better, medicines are better tolerated, and so the hope for people with the more advanced prostate cancer is becoming much, 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 much better. And organ-confined prostate cancer approaches 100% 5-year survival, 98% 10-year survival, and so the idea with prostate cancer is don't be afraid of getting screened, because the implication of what the therapy associated with that diagnosis would mean, because we on this side of that diagnosis are very, very keenly aware of those fears, and we're pushing the envelope of trying to do more precise diagnosis. We're trying to do more precise therapies so that we can be impactfully aware of the quality of life impact of this disease. And the science is trying to catch up and be aware of that alongside you as your partner in terms of the right treatment for the gentleman at the right time, so that we can achieve both in a personalized way.
So it sounds like there's been tremendous progress across the whole spectrum of diagnosis, particularly early diagnosis, identifying risk, identifying intermediate cases, identifying the people that really need to be treated, and then doing as well as possible even at advanced stages. So it's pretty fascinating. And
amazing study. New England Journal of Medicine and Europe, they do studies like this: randomized trial, active observation, surgery, radiation therapy, 10-year, 15-year data, 97, 98% of men alive, or 90, and then 15 years similar, identical, high 90, I think it was 97, 98% at 10 years, 96, 97% at 15 years. However, in the observation arm, more people needed surgery and radiation somewhere along the line, and a slight amount of people needed a hormone blockade because of metastatic disease, but it didn't cause them to pass away. Opens up the discussion of the power of active surveillance appropriately, and it opens up the discussion of focal therapy appropriately when you find the right disease in the properly selected patient. So what that tells people is people may not die of prostate cancer if you catch it at the right time and you find the right treatment, again, for the right gentleman at the right time. That starts with screening at the right time.
Ali, that was an amazing discussion. Thank you for being part of MedEvidence.
I appreciate it. And anytime we can have better and smarter conversations, you're the best person to have these conversations with.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.